Hey there, it's Dr. Atkinson, and today we're going to take a deep dive into IV therapy. Now, I know IV fluids might sound like the most basic thing we do in nursing, but trust me, there's a lot riding on getting it right. Pick the wrong fluid or miss an early complication, and you can turn a routine infusion into a real emergency. So let's start with why we give IV fluids in the first place. 3 main reasons. Number 1, to give water, electrolytes, and nutrients the patient needs to meet their daily requirements. Number 2, to replace water and correct electrolyte deficits. And number 3, to deliver medications or blood products. One big warning here, never give pure electrolyte-free water IV. The second it hits the bloodstream, it'll rush right into red blood cells and pop them like water balloons. Understanding IV solution types. We classify IV solutions by how their tonicity compares to plasma, which sits at about 300 milliosmoles per liter. If it's close to that number, we call it isotonic. Less than that, hypotonic. Greater than that, hypertonic. Isotonic fluids. Isotonic fluids expand the extracellular space without making cells shrink or swell. If you give a liter of isotonic fluid, you expand the ECF by exactly 1 liter, but only about a quarter of that stays in the plasma. A few examples you'll see all the time. D5W, which starts isotonic but flips to hypotonic once the glucose is metabolized. That means 1/3 stays outside the cells, 2/3 moves in. It's great for providing water, but not for resuscitation, especially if your patient has increased ICP or is prone to hyperglycemia. 0.9% normal saline, your go-to for expanding intravascular volume, blood transfusions, and sodium replacement. Just be careful in heart failure or sodium-retaining states. Lactated ringers contain sodium, chloride, potassium, and calcium, perfect for replacing GI losses, sodium depletion, or correcting dehydration and blood loss. One safety note, if you're replacing blood volume with crystalloids, it takes about 3 liters to match the effect of 1 liter of blood or other colloid solution. Hypotonic fluids. These have a lower osmolality than plasma and push water into the cells. We use them to treat things like hypernatremia or hyperosmolar states. A classic example is 0.45% saline, or half normal saline. Remember, hypotonic fluids can make cells swell, so use caution in patients with risk of cerebral edema. Hypertonic fluids. Now we're pulling water the other direction, from the intracellular and interstitial spaces into the vascular space. Examples include 3% saline for severe sodium depletion and mannitol for acute cerebral edema. D5NS or D5LR start out hypertonic, but go back to isotonic once the dextrose is metabolized. D50W, that's strongly hypertonic and needs a central line. These solutions can be life-saving, but they're not casual fluids. Infuse too fast and you can cause circulatory overload, dehydration, and a whole new set of problems. Other IV therapies. IV therapy isn't just about fluids. We give parenteral nutrition when patients can't eat, colloids and plasma expanders to pull fluid into the vascular space, and of course, medications. Because IV meds go straight into the bloodstream, you have to know the rate, dilution, and potential reactions before you hit start. And always check for allergies. IV reactions can go from 0 to disaster in seconds. Systemic complications. Fluid overload is probably the one you'll see most. Rapid infusion or underlying heart, liver, or kidney disease can tip a patient into pulmonary edema. You'll hear crackles, see distended neck veins, and notice weight gain or shortness of breath. Slow the rate, put them in high Fowlers, and call the provider. Prevention, infusion pump, and close monitoring. Air embolism is rare, but when it happens, it's serious. Air can lodge in the right ventricle and block blood flow into the lungs. Signs include sudden dyspnea, cyanosis, low BP, and a rapid weak pulse. Clamp the line, put the patient on their left side in Trendelenburg, and give oxygen. Infection can start at the insertion site or systemically. Fever, chills, malaise, and local redness are early signs, and strict aseptic technique is your best prevention. Local complications phlebitis, chemical, mechanical, or bacterial, shows up as redness, warmth, and tenderness along the vein. Remove the IV, warm compress, and restart elsewhere. Infiltration is when a non-vesicant fluid leaks into the tissue. You'll see swelling, coolness, and discomfort. Stop the infusion, elevate, and use warm or cold compress depending on the fluid. Extravasation is infiltration's nasty cousin. A vesicant or irritant escapes into the tissue. This can cause blistering, necrosis, even limb loss. Stop the infusion, follow your facility's protocol, and sometimes keep the line in to deliver an antidote. Prevention is everything here. Smallest catheter possible, secure it well, and check the site often. Thrombophlebitis is a clot with inflammation. Cold compress first, then warm, elevate, and don't flush the line. Hematoma happens when blood leaks into surrounding tissue. You'll see swelling and bruising. Treat with ice, elevation, and pressure. Clotting and obstruction often come from kinks, slow flow, or an empty bag. Prevention means keeping a steady flow, flushing after meds, and making sure the bag doesn't run dry. Home and transitional IV care. In the home setting, IV therapy shifts a lot of responsibility to the patient and family. Education is huge. Written instructions, hands-on teaching, and return demonstrations are key. Home infusions can include antibiotics, chemo, blood products, and parenteral nutrition. The nurse's role is to monitor, teach, arrange labs, and collaborate with case managers for follow-up care and resources. Final takeaway: IV therapy isn't just hanging a bag and walking away. It's understanding fluid types, knowing how they shift in the body, watching for early complications, and teaching patients how to care for their access safely. When you get it right, you keep your patients safe, their fluid balance steady, and their outcomes better.